Good day. Thank you all for joining us for the second of our Healing the Nation webinar series. My name is Ben Miller, and I'm the Chief Strategy Officer for Wellbeing Trust, a national foundation committed to advancing the mental, social, and spiritual health of the nation. Over the past year, alongside trusted partners, Wellbeing Trust and others have worked to advance mental health and well-being in our nation. Thanks for joining us today. I want to remind you all that this is a webinar that's being recorded. It's going to be available after the webinar so you can share throughout your social networks and with your friends and your colleagues. Throughout today, when you have questions and you want to offer those up as comments, please use the Q&A box at any time, but we will come to questions at the end of our time together today. Today represents our second webinar, and its topic couldn't be more timely. As I'll describe in just a second, the COVID-19 virus has highlighted some of the best and the worst of America. Our resolve, our need for social connection, and also our deep-rooted inequity and profound racial disparities. Make no mistakes, my friends, this virus is not an equalizer, as the playing field was never leveled to begin with. And now it's allowing us the chance to address some of these great divisions in our country. I'm honored to stand beside today's panelists, friends, colleagues, national leaders, amazing people to boot. You'll hear three sides to the problem, or as we call it, the triple threat against our well-being. We will begin with Professor Dana Matthew, who will describe the social threat against our well-being, one that is highlighted by COVID, but one that has been a part of our country for some time. Next, we'll go to Dr. Carol Graham, who will take us deep into the issues of economics and how they play a role in our health and well-being. And last, but definitely not least, we will have Dr. Ashwin Vasan, who will talk about the health implications of COVID with the focus of those folks in our country who have mental illness. Together, we think that we have an all-star lineup, not only to clearly articulate the problem, but to offer up clear solutions for us to all consider. So make no mistake, today represents an opportunity for us to be courageous and to advance with a clear vision of what we as a nation should be pursuing to advance our health. Central to this is our need to recognize that mental health is essential to health as it's always been, but it's at a pivotal point for radical transformation. No tinkering, no polite nod. No, we need something that will shake the current fragmented structures down to their core. Something that allows for bigger and more transformational strategic vision where mental health is central to any redesign that we have. And if COVID doesn't highlight the need for this redesign, it's hard to know what will. The fragile system we already had built around mental health and addiction services was not strong enough to meet the demands before COVID. And now COVID is highlighting some of these cracks in a pretty pervasive way. In a recent Kaiser Family Foundation poll, 1 in 5 folks said it has had major impact, and multiple demographic groups report worry or stress related to coronavirus and how that's had a negative impact on their health. As we've written, mental health was an epidemic far before the COVID pandemic set in. We were already in a crisis before the coronavirus hit, and now our mental health and addiction epidemic festers underneath, potentially growing this underlying problem in our nation. Life expectancy in the United States had already been on the decline, in part driven by unaddressed issues that were some part social, some part economical, and some parts mental health, just as we've structured it today. Deaths to drug, alcohol, and suicide continue to skyrocket, reaching levels that we've never seen. And these issues impact all generations and all ethnic minority groups, though at differing degrees and severity. In the best of times, our country still hadn't resolved itself to the fact that we should be investing in mental health and make it a priority. Now, in the face of this global crisis, it's really hard to expect that our policymakers will make this a priority despite it being foundational for our health, though we must do it. This is why we must be loud and clear in our message. Without addressing and investing in mental health, we are failing families and communities. The bad was already here and could only get worse if we don't come up with a plan. That's where we come in today. This webinar series and so much more is really about how we can heal as a nation. About a month ago, Wellbeing Trust, in partnership with others, released Healing the Nation. It's a federal policy guide that offers a way for Congress to begin to see mental health as essential to health. Because when healthy community conditions, good coverage, and inclusive policies are all in place, we can achieve positive outcomes that improve mental health and well-being of all Americans. This is our charge. As we outline in Healing the Nation, accomplishing this goal requires a comprehensive framework that sees mental health as existing on a continuum that begins in community, around the vital conditions, and extends into health care. We posit that if we're truly serious about tackling mental health and addiction in our country, we must leverage all the places and spaces that people present with needs and to provide support accordingly. We must also see needs as including risk factors as well as mental health conditions, and focus on upstream factors, or vital conditions as I called them, that can prevent or mitigate later problems. And what a better time to have a framework and a plan. COVID is asking our nation to have a plan for addressing mental health and well-being during this crisis, as well as a recovery plan after the crisis. A framework is needed to get this right. Simply looking at the pieces will have us miss the whole, which is what we must avoid. Our communities will need to have a robust plan for our nation to truly avoid a major catastrophe around mental health. For those not familiar with Healing the Nation, you can go to the website. It's healingthenation.wellbeingtrust.org. You can see on the slide in front of you, where you can find out more information for each of these entry points, as well as clear evidence-based policy recommendations. On Healing the Nation, you can see a user-friendly website that really allows you to have downloadable policy briefs that you can immediately use. And while this first guide was a focus on federal policy, future iterations will really be looking at states and ways that we in the community can use the guide. From the framework, you can see the entry points, as you'll see here on the slide, the places where people show up with mental health needs. It's opportunities for us to do a better job engaging individuals, to meet patients, to meet families where they're at. You can also download, as I mentioned, each of these for easy use. And finally, while we're clear on what works, these are not belief-based policies, but really concrete evidence-based recommendations that are needed now more than ever. But it requires us to recognize this moment and to see clearly through what hasn't worked, how more money or more policy that supports the same old structures are not going to bring our community to a different place. After coronavirus, our country is going to have a major problem to contend with that was already here before and is likely being felt by millions even today, even as we talk on this webinar. This is about all of us, but sadly more some than others, as we will learn today. Let's collectively find our voice to demand that every policymaker, from Congress to our local mayor's offices, do something more for our mental health. With that, it is my honor and privilege to turn it over to my friend and colleague, Dana Matthew, to get us started. Dana?
Thank you, Ben. Thank you for this opportunity to speak not only about the mental health issues that are affecting the poor and the vulnerable in our society, but if you'll show my next slide, I'd like to summarize the comments that I'll make over the next 2 minutes for the entire group. Next slide. I have 2 messages that I'd like to leave with the audience today, and they are these. Number one, that the mental health sequelae from this COVID-19 pandemic are going to distribute themselves along the disparities of structural inequality. And that is because structural inequality is in fact the greatest threat to our mental as well as physical health in the United States and beyond. The second message that I would like to leave with all of us is that our willingness to address the structural inequalities that address the most vulnerable in our society is in fact the way that we will improve the mental health and physical health outcomes of our entire society. In other words, we will ignore the vulnerable and the marginalized to our collective peril, not only with respect to COVID-19, but generally. So my first slide describes one of the facts that I think is probably familiar to this group, and that is that inequality in the United States is greater than it is in any of the other industrialized nations against whom we compete and compare ourselves. This, I would suggest, is also the reason that our health outcomes are severely constrained as compared to our competitors. It's not only true in a global context, but when we look at the right side of this slide, you will see also that the ways that COVID-19 has spread around the United States, what we have termed hotspots, also reflects areas of great inequality. In the East Coast, in the Northeast Coast particularly, which is where my hometown is, New York City, you see the tragic concentration of COVID deaths as well as diagnoses. And these are reflected throughout the nation in hotspots where people are densely populated and closely living together and therefore, of course, more vulnerable. Next slide. Of these cities, you see that there is a highly racialized distribution, if you will, of COVID diagnoses and deaths. New York City is the city I want to focus on, but if you look around the country, you'll see, and I'm sure this data is familiar to many, that disproportionately African Americans and Latinx populations are suffering the morbidity and mortality from this crisis, and this is laying bare the fallacy that these inequities are solely the result of medical incidents or medical outcomes. In fact, these are reflections of structural inequalities that we have seen all over the country, and I'd like to focus particularly on New York City because, again, that's where some of the most tragic disparities and the most tragic outcomes generally have occurred. Just for your recollection, you see that the percentage of deaths among Hispanic populations in New York City, which represent only about 24% of the population generally, but 34% of the deaths in New York City. Similarly, among African Americans, which represent 22% of the population, you see a disproportionate 29% of the deaths from COVID in New York City. But look around the country. In Louisiana, 70% of the deaths are African Americans, while 30% of the population is African American. You see that disparity in other parts of the country where structural inequities are prevalent. So let me turn now and talk to those structural inequities in particular. Next slide. One of our colleagues at Brookings saw an opportunity to really highlight these structural inequalities by looking at the data in New York City in particular. And I want to suggest that Rashawn Ray's piece on April 9th of the Brookings report is worth everyone's attention if you haven't seen it. And the reason it's very, very helpful is because not only does it present the data, but it presents an evidence of what a public health intervention would look like if we were to take seriously the structural inequalities that I'm suggesting lead to this kind of disparate data. Rashawn's piece shows us that employment, that housing, and that education disparities are directly associated with these disparities in morbidity and mortality that have affected minority populations, again, focusing on New York City in particular. Next slide. So looking at New York in particular and asking ourselves, why is it that these differences are hitting populations that are marginalized, populations of color, populations who are lower socioeconomic status, wealth, and income? Why is it that it is hitting these populations? Well, again, let's look at these populations by their employment, by their income, by their education, and by their opportunity to avoid the kind of contact that results in transmission of COVID-19. Disproportionately low income and people of color in large cities are those employees that have been described as essential employees. That is, those that have not the luxury that we have of working from home. I'm grateful for this opportunity to be with you by webinar. I've been home ever since March 23rd, but that is not a luxury that the people pictured here have. In fact, 30% of all bus drivers in New York City are people from minority backgrounds. 20% of all food workers, janitors, cashiers, and stockers are people of color and are people that therefore cannot stay home and have to be exposed in ways that those of us who can work from home are not. Public transportation is utilized in New York City by people who are 25% from minority populations. So this picture is a picture of folks using social distancing on the train, but at different hours. If you've been following the press, you'll see that the press of people going to work as essential workers to pick up our garbage, to make sure that we have groceries, and to make sure that our public spaces are clean, are overwhelmingly Black and brown. And the fact that they are concentrated in these income brackets and in these working groups is evidence that, or is fueling their disproportionate exposure to the COVID-19 virus. How did they get to be these workers? How did they get to be concentrated in these areas? Well, for that, there are other structural inequalities that we'd have to pay attention to. We could look, for example, at the public education system in New York City, which is not only predominantly Black and brown, but is now highly segregated in ways that predated or similar to predating the Brown versus Board of Education decision in 1950. In fact, 73% of charter schools, that is the magnet and charter schools in New York City, are reaching apartheid levels of segregation. That is saying that less than 1% of the enrollment in those schools is white, and the remaining 99% is Black and Latinx. That is also to say that where the school system in New York City is highly sought after. An example would be Bronx High School of Science or the Stuyvesant School. Both of those schools are now predominantly white and Asian. In fact, last year, of the 895 slots at the most competitive secondary school in New York City, Stuyvesant, only 6 of those spots went to African Americans. This is how this population ends up being the population most exposed to and most vulnerable to a virus or pandemic like the COVID-19 virus. The educational opportunities that are disproportionately distributed in New York directly impact the employment opportunities as well as the housing opportunities. And therefore, concentrated poverty, concentrated housing opportunities that are dense, and concentrated structural opportunities to be exposed to more mold, more pest infestation, and less safe housing environments and neighborhood environments is disproportionately distributed to the populations that are experiencing the disproportionate exposure to COVID-19 as well. Next slide. So where does this take us with respect to mental health? Mental health, I'd like to suggest, is going to adversely affect people of all backgrounds and all races. In other words, the psychological effects of a disaster know no boundaries by race, by ethnicity, by income. So disasters generally affect the social structures and the supports that people will experience. There will be increased incidents of despair, of shock, of depression, of anxiety. The loss of work, no matter what your color, race, ethnicity, or background is likely to lead to loss of identity, the loss of routine, the lack of control, the fear of socializing, and the fear of uncertainty. This is heightened where those disasters that our populations are exposed to are man-made. Anger accompanies these other mental health impacts. Fear and suspiciousness, helplessness, and there you see some citations to the types of data that I'm referring to. But on this slide, I'd like to focus specifically on minority mental health. And the picture I've shown is particularly important because of the surge in anti-Asian racism that has accompanied this virus. I'd like to suggest 2 things from this slide that are relevant to the minority mental health sequelae that we expect to see from this pandemic. Number 1, those populations that will experience direct discrimination, like those horrible stories that we have heard directed towards Asians as being responsible for, as being carriers of, as being somehow more culpable for this national and global virus, those are going to directly be associated with major depressive disorders that we should screen for and be attentive to in that population in particular. The second point I'd like us to consider is spillover effects from these mental health sequelae. And that is to say that populations that are disproportionately affected, whether they're Asian populations from the type of xenophobia that we have seen horribly surge in our country as a result of the COVID-19 virus, or the disproportionate effect, as I've referred to in earlier slides, on African Americans and Latinx populations, there is copious evidence that these spillover effects will touch general populations, even those who have not had the COVID diagnosis directly. That is, feeling that you are more exposed, feeling humiliated, feeling saddened by as a vicarious matter, and having more poor mental health days as a result of your population group with which you identify having been disproportionately impacted is a mental health outcome that we can expect to see from this disaster unique to populations that are minority in ethnicity and race. Next slide. And so I'd like to close with suggesting some interventions that would address these particular disparities that affect minority populations and their mental health as a result of the pandemic that we're currently experiencing. The first one is not on this slide, and that is that we need data. Data has to be released by race, by ethnicity, and by income so that we can stratify and understand what the impacts from this pandemic are on the mental health of populations that are uniquely affected. If we can't see it, if we can't measure it, we can't treat it, and we cannot cure it. Secondly, since these mental health impacts will mirror the disproportionalities that we have seen by race and ethnicity and by geography, I hope that we will all work to identify and direct the resources that are needed to address the mental health issues of these populations specifically. It would be very helpful if the populations were helped with allies, with others that would begin to see and identify structural inequality, and particularly structural inequality that is racialized. We call that structural racism, and racism I know is a tough word, but it simply means an organized system that gives value to people hierarchically and then distributes resources and opportunity according to those hierarchies. Racism structurally is a determinant of mental health, both directly and indirectly, as some of the studies I've cited earlier suggest, and therefore we should direct our screening and treatment resources to these populations. Lastly, when we play the game for the long term, that is, if we do not want to return to the inequitable society that we were before this crisis, then we should direct and design our mental health interventions to include addressing the disparities that are a reflection of where we work and where we live and where we play. Education, housing, and employment disparities are the structural disparities that we must address if we'd like to really eradicate the mental health disparities that we're likely to see as a result of the COVID-19 pandemic. I want to close by referring to a really encouraging, on an encouraging note, article that we saw this weekend in the Sunday Times, and it referred to the fact that we could emerge from this crisis better than we were. And I hope that these data that I've shown you and some of the disparities that we've talked about will spur the kinds of interventions that will make us a more equitable society, that will make us a better America after COVID-19 has passed. Thank you. And now I'll pass it to Carol.
Thank you, Dana, and also Ben. And as both of you noted, that it's really important to emphasize how much the virus has exposed these deep structural inequalities in our country. I've been following the lack of social cohesion, mental health report increases, as well as declines in physical health, from a new approach, which is well-being, or the economics of well-being, trying to measure well-being as part of the human experience as we assess economic outcomes and other kinds of outcomes. And we combine metrics of well-being and ill-being with econometric tools that economists typically use. And by doing that, we've been able to show deep differences in things like hope and optimism on the one hand, and stress and anger on the other, across rich and poor in the United States. Lack of hope, for example, both stress and lack of hope are linked to deaths of despair. We've been also using the metrics to track deaths of despair and at the level of the individual and level of county, and have basically shown that if we'd been tracking metrics and signs of ill-being in this country, we might have caught the deaths of despair issue well before it turned into such a crisis. So next slide, please. So before COVID, I was already noting that there were really deep, what I called progress paradoxes in the US, that while sort of at the central policy level, people were talking about booming stock markets, record low unemployment levels, and steady growth, that we were also seeing 20% of prime age males out of the labor force, just having given up and dropped out of the labor force at prime ages, rising mortality rates among the middle aged due to preventable deaths such as drugs, alcohol, and opioid abuse, and other signs of social stress and despair. And the group that was particularly hit are less than college educated, often the low wage workers that Dana is talking about. Although what was interesting and seemingly paradoxical about our initial looks at the deaths of despair were that that this was predominantly an uneducated white problem. Blacks and minorities are underrepresented in the deaths of despair, which is a good thing. It doesn't mean they're not in the category at all, but they're really, in percentage terms, much lower than whites who are in the deaths of despair category. So to try and understand this a bit better, and even before the deaths of despair, a lot of my work was looking at why well-being matters and finding that more optimistic individuals are more willing to invest in their futures and they tend to have better outcomes. We also find that people in deprivation who have lower expectations and lower levels of optimism tend to focus on daily experience as they lack the capacity to plan ahead. Life is very stressful. It's driven by circumstances beyond your control a lot. If you are in one of these insecure low-wage jobs, you often don't know your schedule the week before. If you lose your job, you lose your health care. If your child gets sick and you can't go to work, you lose your job. There's sort of this vicious cycle that affects people at these levels of income and with the kinds of jobs they have that lead to poor health and poor mental health as well. And what we find is that what I call bad stress, which is stress associated with circumstances beyond your control, not stress associated with goal achievement, is a strong marker of both ill-being and poor health. And it's also has strong links to deaths of despair patterns, as does lack of hope. So the US, compared to other countries, stands out for having very large differences in these markers across income cohorts, the rich and the poor, and then also across races. And so we find that the US stands out for having unequal hopes, lives, and lifespans across income levels. And I think the slide that Dana showed on our inequality is sort of the macro picture, and this is the micro picture of the same phenomenon. In some comparisons I did starting out, I was quite surprised to see that the US poor were more likely to report having experienced stress the day before than the poor in Latin America. And of course, the poor in Latin America are materially much poorer than our poor. So this is a sign of the high cost of being poor in a rich country, in my view. And then we also found, even more surprisingly, that the poor in Latin America are much more likely than the poor in the United States to believe hard work will get them ahead. And that's a classic American dream question. If an individual in this country works hard, can he or she get ahead? Yes or no? The poor in Latin America are 20 times more likely to answer that question positively than the poor in the US. And I think that's a stark marker of our deteriorating social cohesion and sort of all these other things we're talking about. So that was before, and then enter COVID-19, which has given an exponential shock to the health, living standards, and mental health of the country. And again, it's concentrated among low-wage workers, among the same cohorts already vulnerable to deaths of despair. And the trends are overwhelming. Over 22 million unemployment claims in the past 4 weeks. Our unemployment rate, our record low unemployment rate is now at 20%. And we also, that masks anything happening in terms of trends in labor force dropout or other trends in mental health, which, as Dana mentioned, we really need to measure better than we are. So let me tell you very quickly a bit about how we measure these things and then how they link to deaths of despair. So next slide, please. So nobody wants to see an equation, I'm sure, but just for a second, bear with me. It's just important that you understand how we do this. So basically what we do is we have these large N equations. We have observations for 1,000 Americans a day for the past 12 years in the Gallup Daily. We also have worldwide data, but we'll stick with the US right now. And so we take as the dependent variable, the well-being of individual I at time T, and that could be stress, reported stress. It could be hope for the future. It could be life satisfaction or happiness. It could be anger or worry. And then we have a vector of demographic and socioeconomic characteristics. So we control for income, age, gender, employment status, rural, urban, a whole range of things that tend to have pretty consistent patterns. And then the error term captures what we can't measure, and sometimes that's innate well-being, and so it's an important part of this story. There's some things we can't observe about people, and they're naturally happy people and naturally unhappy people. But that aside, using these standard equations and consistency in the roles of income, age, health is very important to well-being. I should have mentioned that first. We're then able to control for the well-being effects of things that vary more. So, for example, changes in the unemployment rate, or inflation, or behaviors such as smoking, drug addiction. We can measure how all these things affect well-being or ill-being across millions of people across the United States. So forget about the equation, but the main thing to take away from this slide is that we're not asking people if particular things make them happy or stressed or worried. We don't say, does the inflation rate make you unhappy? Or does the COVID crisis make you unhappy? What we're doing is, people don't know that when we take their well-being report up front, that we are then comparing that to variance in these other things. That they answer those questions, but they aren't linked for the respondent. So next slide, please. So this is, and it will make you happy or unhappy depending on where you are on this curve, but this is an incredibly consistent phenomenon that I and a few others have found to be consistent across 130 countries around the world. And it's a U shape in well-being. Here it's life satisfaction in the middle-age years, roughly 40 to 60 in some countries, but that's remarkably consistent. It also holds, there's an inverse U for reported depression, for stress, for lack of sleep, and even for suicide in those same years. So there's something about these middle-aged years. I can't go on too long about it due to time, but there are many reasons for it. Aspirations aligning with reality. There's a lot up there. We're controlling for age-adjusted health, but there's a lot of psychologists talk a lot about emotional well-being increasing as people age. There are also a lot of burdens in these middle-aged years. People typically hope to be employed. They have obligations to children, to elder parents, and all sorts of things that make these, and then there are a lot of time pressures on people in this age. So it's a difficult period in life for everyone in a way, but it's particularly difficult for people who face serious income, health, or other constraints. So next slide, please. So when the deaths of despair were first written about by Ann Case and Angus Deaton in about 2015, I was already looking at these metrics. We already knew about this age curve, but what's interesting is that the deaths of despair, they've now spread a bit, but they still concentrate primarily in the middle-age years. Again, a difficult time for people, and even more difficult if they lose their job, if they're out of the labor force, whatever it might be. If you look here at this slide, you can see the red line, this is compared to several other rich countries, is US non-Hispanic whites. That is what is driving the mortality trend, at least in the aggregate, to the point that our life expectancy has decreased rather than increased over the past several years. If you look down in the middle, you see USH, that's US Hispanics. So they have, they trended downward in terms of premature mortality, as did US Blacks, starting from a lower level of life expectancy, to be sure, but making very gradual progress as opposed to US non-Hispanic whites. So there's some puzzles in this story, but the well-being metrics seem to bear them out. The next slide, please. So before the deaths of despair even came out, I was, having seen these very stark markers of inequality and well-being across the rich and the poor in the United States, I decided to look across races. I'm going to focus on Black and Hispanics because they're the biggest population groups versus whites. Now, these are only poor groups, so the left out category is a 1. It's poor whites on the vertical side. And as you can see, poor Blacks are almost 3 times as likely to report on, a step up higher on the optimism scale, it's an 11-point scale, than are poor whites. Hispanics about 1.25 times more optimistic than poor whites. Now, obviously, when I first found this, I was surprised. Now I understand it a lot better, and it's very much a resilient story, a story of community ties, and lots of other things that seem to be protective of the mental health of Blacks and Hispanics, at least compared to poor whites. I'm not saying it's a great story, but they seem to do better. Blacks and Hispanics are also less likely to report stress the previous day than our poor whites. Again, I don't think objectively they experience less stress in a day, but they are more resilient. Again, I could go into these differences in greater detail, and happy to in questions, but this pattern continues to play out when we match our metrics of well-being and ill-being and deaths of despair and deaths of despair incidents, and we find again that Blacks and Hispanics and the places where they live are much less likely to have high levels of deaths of despair. So next slide, please. So going forward, as I mentioned before, sort of what can we do about this? In part, I think we have to learn from these differences. In part, I'm not sure we really know, but there are plenty. I think if we have so many people that know different sides to this story, that putting heads together is a first step. And as Dana mentioned, measurement is really important. We can't do things, good things to help with mental health and other trends if we don't know they're there. So first of all, and a very easy thing to do, is to track well-being regularly, as for example, the Brits do, the Canadians do, the government of New Zealand does, which is just to include these metrics of well-being and ill-being in their national statistics collection. It's 4 questions that answer about 30 seconds each to ask, so it's not expensive. That's a poor excuse. And we, in our matching of the well-being and ill-being metrics, and in particular, the 2 that stood out were lack of hope and stress, in terms of being as positively associated with deaths of despair, we really find that the declines in hope predate the deaths of despair by 2 decades. So we clearly would have had warning signs had we been tracking well-being regularly. That's an easy thing to do, and it also helps us track trends in mental health. One of the things that we don't know with COVID, which does make it different, is that COVID, as Dana mentioned, is so far has had higher incidence in urban places and is much more concentrated among low-wage workers, among Blacks and Hispanics. And so far, the rural, mainly white counties that are most vulnerable to deaths of despair, which tend to be counties with hollowed-out communities, and so they not only have lost their economic livelihood, but their sense of community and community spirit. It hasn't hit there yet as much, but we don't know what's going to happen when COVID hits rural counties. I think personally that because of lower population density, incidence rates will of course be lower, but I think mortality rates will be higher because in these rural counties, they disproportionately have very low levels of reported well-being and very high levels of existing conditions like diabetes, heart disease, a whole range of them. And they also tend to have worse health behaviors, high levels of smoking and high levels of opioid consumption. So I think the story on COVID is still out as it spreads to the rural communities, but I think it will be another part of this story. So just to give a sense economically of the links of some of the economic shocks, it's, predicting is a bad idea in my view, usually because it's hard to do. And we know very little about this virus, except that it's deadly. But just some past studies found, especially an NBR 2017 paper by Chris Room and others, found that a 1% point increase in the county unemployment rate tends to be associated with a 3.3% increase in the rate of drug-related deaths per 100,000 people in the same county. Now, if you think about our unemployment rate has gone from about 4% to 20%, and these places that were already hard hit, that's a huge increase in places that don't have a margin for that sort of increase. They don't have a margin economically, and they don't have a margin in terms of mental health trends. So that's a very big challenge, and obviously some of that solution has to be economic, but there's much more to it. And I think the mental health side of the story is a really big issue. And then finally, and I don't have enough time to go into detail, but the social distancing that is absolutely necessary for survival to get over the virus also eliminates one of our key tools for reducing isolation and despair and increasing well-being. And a lot of those tools have relied on getting isolated, desperate people back into the community, trying to give them a sense of purpose, and doing that through community-related activities. We need new approaches. There's obviously in the short term going to be a role for some sort of technological reach. Of course, that's difficult in places that don't have equal, good access to the internet, but it's something that we can, at least in the short term, think about. Just today, there was an article from National Public Radio showing that now access to opioid treatment and visits and also to needed drugs for people going into withdrawal and they're trying to get off opioids can now be accessed through video chats with their doctors. So there's lots more to learn and think about there. So speaking of that, I'm going to turn it over to our resident doctor, Ashwin Basan.
Hi, everybody. It's wonderful to be here. Thank you to Ben, thank you to Wellbeing Trust, and thank you to Dana and Carol for your great presentations. I'm going to come at this in a slightly different angle because I wear a couple of hats. One is as the head of a direct services, human services agency that focuses on mental health, and specifically that focuses on people with chronic mental illness, serious mental illness that really are already disproportionately marginalized and already disproportionately at risk of social isolation and the deleterious health and social impacts that result from that. And so I spend a lot of my time thinking about how do we keep folks like that connected, and how do we ensure that they don't fall through the cracks as they're wont to do even under good circumstances, even under normal circumstances. Number two, I'm a frontline healthcare provider who's still providing primary care in the midst of this pandemic. And in addition to my observations from the clinical environment, I look at how much untreated, unaddressed, unseen burden of chronic illness there is in the midst of a virus that's really just overwhelming the system. And then finally, and I very much appreciated Dana's presentation in this regard, I'm someone who has in past lives and in this current job really look at the intersection of vulnerability and structural inequality, structural inequities, along whether it's along race or along other modes of marginalization. And so Fountain House is a nonprofit charity that is founded 70 years ago in New York, and has spawned over 300 replication projects in 30 countries, or nearly 200 in the United States, which broadly fall under the category of psychosocial rehabilitation. Now that sounds pretty niche, and certainly it's been funded as niche by the federal and state authorities. But really, it's much more than this. We are involved in integrated primary care and behavioral health care through the federally qualified health system, supportive housing. We're one of the larger supportive housing providers in New York City, and many of our affiliate projects do the same, and so forth. And so we really see how human service agencies like ours are being affected in an era of social distancing. And as I mentioned, we look at people who are disproportionately socially isolated, and we look at how a disease which is striking at the very heart of attempts to bring people back into the fold and keep people connected, how programs like that are managing. I think about that all the time. So next slide. I was asked here to kind of comment. Next slide, please. So I was asked here to kind of comment on overall health impacts. And so I'm sort of wearing both of these hats as I make comments about, back one slide, please. I'm sorry. Yep, back one slide. Thank you. Number one, and something I'm seeing very clearly amongst my colleagues, and particularly concerning amongst young trainees, the residents and training doctors that I supervise, is trauma. So that's vicarious caregiver trauma that's being experienced on the front lines, individual trauma from facing the risk of illness or actually experiencing illness oneself, let alone the direct and indirect individual and collective trauma that's being faced by affected communities, affected families, and the like. You know, I had a 21-year-old member of ours over the weekend who had both parents hospitalized at the same time, both unaware, completely separated, and unaware of what the outcomes were. And unfortunately, his father passed away. And you know, the long-term impact of that is something that I don't think we can even begin to describe the magnitude of that, other than to say we know the mechanisms, we know the biologic and social mechanisms of trauma and its impacts on long-term physical and behavioral health. And so given that we understand that, given that we know that risk, and given that we are suffering as a society a collective mass, I mean, akin to a mass casualty event or a mass disaster, we need to put into place guardrails to and programs to really support people's long-term health who have been disproportionately impacted by the pandemic. The second bullet, you know, I don't want to belabor the conversation around testing. It's clearly something that's being talked about in the popular media quite a bit. But why do I mention it here? In part because it's impacting our ability to really measure and understand the wide-ranging health impacts of this virus and really who's being affected. We have in New York City nearly 9,000 people who have been confirmed dead as a result of the virus. Another almost 4,500 people who are thought to be probably deceased due to the virus, and then another 4,700 excess deaths, excess mortality compared to normal situation. A proportion of which, unclear what proportion, a proportion of which is either directly due to the virus or indirectly due to untreated, under neglected care, delayed care, and the like. And I'll just say, as someone who's doing telehealth in part during this crisis, the overwhelming number of patients I hear and speak to who are dealing with chronic medical issues that we're just unable to attend to, things that we would ordinarily very much bring them in, whether it's heart failure, or you saw the New York Times report over the weekend about dialysis beds. I mean, this is truly an unmeasured epidemic that we're not even scratching the surface on. So it's the main reason why I bring up testing. Dana did an excellent job of outlining the disproportionate impact on communities of color. You know, I commented on this a few weeks ago when the city published their first map of where COVID was happening, and it looks like every other map of every other health and social condition in New York City, the same concentrations of illness, concentrations of systemic poverty, concentrations of people of color, of frontline workers, of working class people, of marginalized people. So it's no surprise then that the virus has simply exploited those fissures in society and those structural inequalities. And so as we start to think about our overall epidemic response, we need to address that with intention and with strategy to go into those communities and really work back against the well-earned mistrust, the well-earned issues and barriers to care that those communities face disproportionately. And so I'm glad that was a focus. I mentioned the untreated and unattended chronic illness. And you know, the thing that we can all relate to is the unknown long-term impacts of social isolation and physical distancing on health and mental health. Some estimates have suggested, a big meta-analysis from a few years ago, suggested that social isolation is equivalent to smoking 15 cigarettes a day. Well, now take that in our own lives, let alone in lives of people who are disproportionately faced with isolation prior to the pandemic, whether it's people with serious mental illness, chronic homelessness, people with histories of incarceration, people who are refugees and new immigrants to this country. You know, we need to lift up that data and lift up those stories so that those communities don't continue to face the disproportionate burden of this illness, and that we don't use a pandemic like this that affects everyone as an opportunity to sort of sweep those structural issues kind of under the rug. I agree completely with Dana. This is exactly the kind of opportunity we need to reach into those fissures and start to do redesign, structural redesign. Next slide, please. So the coming tide that everyone's talking about, but no one really understands the full dimensions of, is mental illness. Mental illness at the individual level, the household level, the community level, and amongst specific groups disproportionately impact. We're starting to see the public narrative turn a little bit towards this issue as we start to wrestle with what reopening looks like. When will we be back to quote unquote normal? Next slide, please. And so what does that data show? I'm sure many of you saw the recent Gallup poll from just a few days ago that talked about mental health being the % issue that are on Americans' minds as a result of the pandemic and their own lives. And with nearly 70% of people saying they're happy to wait, 54% of people saying that they can put up with the economic hardships, but nearly half saying the thing that concerns them the most is in doing so, in tolerating this social distancing and lockdown, what it's going to do to their mental health. And that's particularly true amongst younger people and millennials, for whom we know mental health issues are among the top 6 of the top 10 conditions that affect millennials are behavioral health conditions, whether it be substance use disorder or diagnosed DSM mental illness. Some of you might have seen a recent McKinsey report, a survey from April, which surveyed about 1,000 people. And again, it showed about 80% of people expressing a moderate or high level of distress, 58% of respondents reporting being anxious or anxious and depressed. 1 in 4 people reporting having binge drinked in the last week. 1 in 5 reporting that they have used prescription drugs for non-medical purposes, and 1 in 7 having reported using illicit drugs. So when we start to try to, and let alone what we know already about the directly proportional curves between income inequality, I appreciated the Gini coefficient slide on the first go from Dana, and suicide rate. So as we start to talk about, as we start to flesh out the bounds of a conversation around the coming tide of deaths of despair, I think the first thing we need to say responsibly is that we are likely to see an increase. And I think that message needs to come out soon. I agree, forecasting is hard and we don't do it very well. But if you start to look at the numbers of just how much collective stress, anxiety, and how few outlets people have that are therapeutic or healthy coping strategies, to say that we are going to see a correction in that life expectancy curve would probably be inaccurate. So if anything, I would be sort of warning our officials that we're likely to see more, even if we can't yet estimate the magnitude of that. Next slide. So what do we do about this? A really excellent Wellbeing Trust report, I think that just came out, suggests that around 111 million people live in a mental health professional shortage area. That's 1/3 of Americans. I think it's the same report we're discussing now, so I'm just giving that flag. And the relaxation of rules around telehealth and telemental health and the reimbursement around that, the temporary relaxation of those rules has been a real game changer for frontline providers like me. My ability to stay connected, to send messages to my patients and to get reimbursed for that activity is just essential and must be. And we should already be starting the process of codifying those rules into permanence, because if we are while we make efforts to increase the mental health workforce, we have got to really reach into communities that are completely overlooked by mental health services, and for whom the cost of mental health services, particularly in a place like New York City, where it's highly privatized and outside of insurance networks, we've got to make that much, much, much easier to access for the people most directly and disproportionately impacted. So I'm encouraged by this, and it has to be a permanent thing. I also think and alluding to the unemployment numbers, and not to get too, political on a policy call like this, this is exactly the time where we need to start having the tough conversations about employment and insurance coverage. If ever we were going to have a substantive discussion about it, it's now, and not one that should not be polemic and should not be politicized, but is really starting with the 22 million people projected to grow, who have just filed for unemployment, who will either lose their insurance or be unable to afford their premiums. We have to start having the difficult conversations about what a glide path to universal health coverage looks like in meaningful terms, and in ones where we realize that if you don't shore up that system, this is exactly the resources that we're going to be demanding of the federal government in terms of direct income support, right? It's going to either come from one pot or another. And I think it's time we started to have a more interconnected and holistic discussion about that. Number two, what's sort of dear to me in particular is how do we protect vulnerable populations? When it comes to children, we have to think about the 21 million people who lack broadband access in our country, and the students out of school now who disproportionately low income and disproportionately students of color who are struggling to remain connected and may continue to struggle even if we reopen schools under new socially distanced and staggered schedules. There's going to be some requirement for online learning, and unless we really talk about some real dramatic and ambitious infrastructure projects to connect people, I think we're going to be struggling. The elderly, particularly, we're seeing difficult stories about nursing homes and really tragic outbreaks in those settings. In the immediate term, we need to be deploying community testing resources out to these high-risk nodes. And we need to be doing that yesterday. And so I hope that that'll be a part of the strategy, not beyond the local level. And of course, as I mentioned, vulnerable populations, whether it's the homeless or the seriously mentally ill, or I know there's lots of attempts, particularly here in New York City, to decarcerate our jails. We also have to be looking at that in terms of immigration detention and the risk that that poses. We have to realize that leaving any population, whether it's by race or other vulnerability, uncovered is it's not just a moral issue, and this isn't just advocacy, this is actually basic public health, right? You cannot leave outbreaks festering in certain locations and then expect to have epidemic control, because those outbreaks will throw sparks. People will eventually transmit outside of that contained environment. You saw this in Wuhan. They did a mass lockdown and they achieved some flattening of the curve, but they weren't able to actually achieve control until they started to deploy shoe leather public health. And the same thing is true for these controlled setting, institutionalized settings. And lastly, I think Carol alluded to it, but I think we need to be talking to a little more about what does the future of direct income support look like, particularly in light of that 22 million projected to grow who are unemployed. Are there going to actually be jobs in the sectors that they're employable in to go back to in 4 months, 6 months, 12 months? I don't know. I don't know if any of us know, but I think there's some good reason to hypothesize that that might not be the case. So what do you do? What do you do for those folks? This is like, taking an example like a Detroit or a Cleveland or an area that's undergone rapid automation and deindustrialization, and then saying, what are we going to do to protect workers? Well, we now have to do that on a national scale, and we have to think about that now. And so, again, beyond the polemic, beyond the political, we need to be talking what material support into people's lives looks like. And so I just want to leave you with a quote from one of our clients. Next slide. Which really ties together the idea that we can't leave people overlooked. This person, Bianca, says, I know a lot of people are experiencing the isolation that many of us with mental illness have experienced for so long. And I hope that when they return to normal workday lives, that part of them still remembers this feeling and that they don't forget about us. So we not only need to not forget about these populations now, but we need to see ourselves as interconnected. These are not just other quote unquote marginalized people and vulnerable groups. These are people who are experiencing a more severe version of what you and I are experiencing right now, which is disconnection. And so how do we bolster our society and bolster our country to keep people more connected? And that'll impact the least among us as well. So thank you.
Thank you, Ashwin. Yeah, so a psychologist, a lawyer, an economist, and a physician epidemiologist walk into a webinar. This is what you get, folks. The chats have been outstanding on the side. The Q&A is, well, the questions, we haven't had any A yet. The Q is robust. We're going to run out of time here, but I'm going to ask our panelists if they can stay on for a couple more minutes. I'm going to ask one question, and then what we're going to do is take these questions and answer them offline so that we can give you some of these answers to the questions, because they're going to take some more time than we have. Before we do, let me just make sure that folks understand this is a series of webinars that we're hosting. They are intended to be comprehensive, to go deep on various aspects of how we can approach issues around mental health and well-being. You can see the rest of the webinars on your screen in front of you. So my one question I'm going to get to today for all three of our panelists before we disperse is, what does structural redesign look like in a post-COVID era when state budgets are being decimated? How do we pay for this amazing work that we're talking about here today when we know that our states are going to be up against it with their budgets? They have always been up against it. And financing can frankly become one of the biggest barriers for talking about doing innovative things. I'll open up to the panelists and then see what answers that we have. And then we'll make sure that we follow up with everybody on this webinar with the slides and the additional answers to the question. So Dana, Carol, Ashwin, any thoughts on that question?
I think obviously financing it is a huge issue. I think it's gonna have to take a federal role. I think we should be thinking about that already. There's already been debate about, well, are we doing enough for low wage workers and their instability as opposed to, you know, giving businesses money? I mean, both have merits, but I think the former has been underemphasized in the current bailouts or stimulus packages, whatever you want to say. I think we also have to think in a structural way that the big failures in our health system had to do with how decentralized and fractured our social safety nets are. They vary tremendously across states. Typically, the states that have the worst health indicators tend to have terrible safety net programs, whether it's how much access through the ACA or food stamps and everything else. I mean, these things are related. And I really agree with Ashwin that it's time for a national conversation about a system that works for society as a whole in terms of health insurance and provision, in terms of safety nets that help people or support people when they fall out of when the bottom falls out. We don't have that now. We're the only rich country in the world that doesn't have it. It's very doable. There are countries that grow as fast as us and that don't have overwhelming tax burdens that manage to do it better, and they've weathered this crisis a lot better because this was like throwing a match at a huge can of gasoline, and a very weak system just has fallen apart, and it's time to restructure it. And certainly states can play a role in implementation and all setting priorities, but it's got to be something that we think about as being financed by our federal government and by the nation as a whole.
Thank you, Carol. Other thoughts?
Yeah, I can agree more. I mean, I think part of and I know why you asked the question the way you did, because I think it's exactly it's just an analog of what we're facing in terms of the epidemic response. I mean, we need federal leadership here. You know, states and local authorities can only do so much. They can only leverage so many resources. They can only hire enough people and to do the boots on the ground work. And extend that analogy into recovery. It requires really forward-thinking, ambitious, long-term, generous, empathetic leadership that wants the best for our society and realizes that we're interconnected in ways that we don't even historically want to see, but this virus has brought to the fore in stark relief. And so until we accept that, it's going to be a challenging conversation to catalyze, but we need to have it. We need to have it, and we need to understand that, more than anything, epidemic response and recovery is the closest thing to a command and control exercise that we have in public life and public administration. And so it all starts from the top.
Thank you, Ashwin. Dana?
I want to agree certainly with what Carol and Ashwin have said. But if I may, I want to take issue with the premise of the question, because it's how we ask it all the time, and it suggests that making a collective, community-wide, federalized response is actually going to cost more. And what I want to suggest is that it's going to cost less. What we are spending on right now is the expensive version of a healthcare system. What we're spending on right now is the way to overspend on waiting until people have the extent of comorbidities. Just like I want us to stop talking about the individual levels of health behaviors and comorbidities that might be causing disproportionality in these vulnerable populations, what I'd like to suggest we stop doing is thinking that we are going to actually spend more money by solving a collective action problem that we're solving piecemeal. I think we'll actually spend less. So the way to do it is to start looking at a cost-benefit analysis that realistically compares what we're doing now to what we could be doing if we had coverage universally for people to be able to access care, mental health care and behavioral care and substance use treatment on a preventive basis at early interventions, and compare those interventions to the kinds of costly ways that we treat people now.
Well said, all. Well, I want to thank each of the panelists again for your time today, your expertise. We could talk for another 6 hours, and I realize we do not have that time. Thanks for all of you that have joined us today. As I mentioned in the chat and the resources mentioned in the chat, as well as the PowerPoint slides and the future answers to the questions that have been posted, will be lifted up and emailed to you all, as well as posted on our website. On behalf of Wellbeing Trust, thank you all again for your time today, and we wish you all the best.